Good morning, everybody. We start our second day with the session number 4 about reproductive medicine. It gives me great pleasure to introduce Dr. Marco Pucciarelli, a consultant in endocrinology and infertility at Cecchino Santori Hospital in Locarno in Switzerland. He will talk today. The first talk is about endometriosis and infertility, the current concepts. Please, Dr. Pucciarelli.
Thank you. Thank you, Dr. Gibrel, for your introduction. Hi, everybody. First of all, I would like to thank the organizing committee for this kind of invitation. It's a great pleasure and honor to be here in the first international conference in Bahrain within so many distinguished colleagues. I was asked to talk about endometriosis and infertility. We can spend 2 entire congresses talking about these topics, and I tried to keep it within the 20 minutes I was given. As you know, endometriosis is a benign gynecological disease characterized by mainly pain, superfertility, and associated with substantial reduction in the quality of life of our patients. Is characterized by the presence of endometrial cells, endometrial tissues outside the normal places, so the inner uterus. And the places, the ectopic site in the pelvis that are always most frequently interested by the disease are the neighbor organs of the uterus, so bladder, bowels, vagina, and peritoneum. But endometriosis could be found even far away. The lungs, brain, has been found in men. The only organ in which it's not been found is the spleen. You know, there are many symptoms that characterize this disease, but mainly the pain. Pain declinated in many ways. Severe dysmenorrhea, deep dyspareunia, chronic pelvic pain, ovulation pain, pain during the menstruation, and interesting with involvement of bladder symptom or bowel symptom if these organs are involved by the disease, infertility and chronic fatigue. So an extreme differences symptoms. And I used to say that each woman has got its own endometriosis clinics. And the quality of life is strongly affected by the pain mainly. And an aspect that always interests are the sexual life. So another connection with infertility. There are many theories advocated to explain why this tissue is present outside the uterus, but the most accredited one is the retrograde menstruations. So during the menstruation, part of the blood reflux in the pelvis and part of these cells can attach and develop on the different organs. And like the normal tissues, these tissues respond to the hormonal input and grows and create all the problems we know. But however, since retrograde menstruation is essentially universal, so every woman has got this problem, but not every woman has got endometriosis, there should be other factors affecting and influencing the development of the disease. This could be individual variation, genetics, immunology, medical or physiological comorbidities. So the result of the clinical disease is comes from the interaction between the woman, so the genes, genetics of the woman, age, race, immunology, as we said before, the lifestyle, diet, lifestyle, childbirth, steroid intake, stress, age, and environment. That's the reason why each endometriosis is unique and peculiar. As you know, the classification, the staging of the disease is a surgical staging proposed many years ago by American Association of Reproductive Medicine and then stated by the American Fertility Association. It's a surgical staging dividing the disease in minimal and mild, so not so important, let's say less severe, to stage moderate to severe, depending how the endometriosis is present and affected the organ inside the pelvis. And you can see here, in the superficial lesion, you can have the classical young lesion, the red spottish, passing through the brown, then to the whitish one. Then could be involved the ovarium with the development of the endometriomas, so the chocolate cyst, or they can, in the severe endometriosis, all the organs are affected. You got adhesion and infiltration of the organs like bladder and bowels. Back in 2010, was published a new tools, not new anymore, that was an association between the surgical staging to the prognosis to get pregnant within the 3 years after the stage of disease, the EFI, so Endometriosis Fertility Index. And this is quite a useful tool that can help a clinician to reassure a patient with a good prognosis, but mainly not to lose time and to start with the right intervention and therapy for those with a bad prognosis. So the diagnosis of the disease is mainly clinical, then corroborated by physical examination, but the gold standard to diagnose endometriosis remain the surgery, so the laparoscopy with the direct vision of the lesions, and so the staging of the endometriosis and the confirmation with histological findings. Unfortunately, even if we are more aware now about the problem of endometriosis comparing to many years ago, the diagnosis still remains a problem, and sometimes the diagnosis still remains delayed. And there are some interesting work stated that sometimes there is a delay of diagnosis of 8.5 years. And you can imagine, we are talking about infertility, endometriosis, and for the fertility problems, the time is such an important aspect. And age of the women remains one of the most important prognostic factors. So delay the diagnosis means delay the treatment, means delay the result to have a baby for these patients. The prevalence of endometriosis is around 10% in women in the childbearing age. And there is a higher prevalence in infertile women, more than 50%, compared to the general population. So there is a clear connection between endometriosis and infertility. Moreover, the monthly fecundity rate, that is approximately 15 to 20%, decrease physiologically with the age, and we know that, but in women with endometriosis can be reduced to 2 to 10%, and even more for severe diseases. But how endometriosis affected infertility? In many ways, and depending on the stage of the disease. For mild or minimal endometriosis, there is an oocyte impairment of the quality due to a reduction of the ovarian reserve, an increase of the apoptosis in granulosa cells, and abnormal follicular fluid environment with an excess of cytokines with a sort of pro-inflammation situation. Moreover, there is a reduction in fertilization due to the disrupted acrosomal reaction and the inhibition of the spermatozoa-oocyte bond, and there is a reduction of the sperm motility. And the inflammatory cytokines are not only within the follicular fluid, but are present also in the peritoneal fluid, and this is determine an embryo toxicity increased and a compromised fertilization. And there is an embryo impaired implantation connected to a low amount of integrins and leukemia inhibitory factor and a low expression of the homeoblox genes, both important for the implantation process. For more advanced disease, the impairment, is connected with the anatomical problems connected with the disease, so the obstruction or distortion of the tubes, the impairment of the site release owing to pelvic adhesion and or endometriomas, and problem connected with the expression of the gene for estrogen receptor and progesterone receptor. So the disease affected in many ways the possibility to get pregnant for these women. I just will focus the presentation only on the problem related with endometriosis. We don't have time to discuss the therapy for pain and other aspects of the disease. So what we can do, which therapy can help us to help these women to get pregnant as soon as possible? The question is, are hormonal therapy effective for infertility-associated endometriosis? Well, the answer is no. With hormonal therapy, we think about the generic analog therapy. There is no evidence that adding and using this drug for this patient help to conceive naturally, spontaneously, quicker. And this comes from the revision of 25 randomized clinical trials. The use of generic analog to have a natural conception in this patient, it's only increasing of cost and delay the time to pregnancy, but it's not useful. Is surgery effective to help a spontaneous conception in these patients? Well, the guidelines coming from the major international professional association do not support the routine laparoscopy for women with unexplained infertility, just to detect and diagnose endometriosis, although we have suspicion of there is problem connected with the presence of symptoms that could be related to endometriosis. In this case, when infertile women complain of moderate and severe pain and prefer not to seek conception with heart, with assisted reproduction technology, the laparoscopy could be a useful tool. Even because if a patient undergoing a laparoscopy for any reason, and there is the presence of stage 1-2 endometriosis, the excision and ablation of these lesions can be helpful in this case to increase ongoing pregnancy rate. And the fact that destroying the lesion, even in the superficial endometriosis, can be helpful comes from other evidence. If we compare the result in terms of ongoing pregnancy and pregnancy rate, 4 women underwent ovarian stimulation plus insemination for unexplained infertility, and those underwent the same procedure treatment for endometriosis, the risk of getting, or the chance to get pregnant are much higher for those with unexplained infertility. But if we treat with a laparoscopy and we destroy the lesions, and then the patient goes within a short period of time to the same procedure, the chance of getting pregnant becomes the same. This stating how the endometriosis can affect the result. Some years ago was quite clear, and this comes from this consensus in Australia, the Australasian expert panel of trial evidence, that doing a stimulation with IUI was better than doing nothing for this patient. Now this idea is a little bit debated. Recently, as we published this paper from Italy, in which many opinion leaders comes together and discuss based on the evidence, and the result that maybe is not so clear that the IUI plus stimulation is useful. And this could be reasonably explained because the chance of get pregnant after 1 cycle of IVF is higher compared to the cumulative pregnancy rate after 6 IUIs. And on the other hand, if you think about the pathogenesis of disease, if you're saying that sometimes the problem is related to the follicular fluid, cytokines, inflammation of the follicular peritoneal fluid, we do not bypass this problem with the IUI, but we do with the IF. If a patient undergoing laparoscopy for endometriomas, we should be aware that the best therapeutical tool is not to just drainage and to coagulate the lesion, but to take out the capsule of the endometriomas. This to reduce the recurrence of disease and to avoid to cook, literally, the ovary and destroying the normal tissues with electrocoagulation. And for higher stages, 3 and 4, they usually are very symptomatic. The laparoscopy and the surgical management is useful in terms of increase in spontaneous pregnancy rate. Okay. But what to do before, I work in IVF clinic, I deal about infertility. What to do before in IVF when the patient has got endometrioma is still a big debate. And it's been discussed for many, many years. In the past, the solution was, when in doubt, cut it out. So the best way was to do surgery anyway. Now, many evidence comes out that surgery sometimes can be detrimental on the ovarian reserve. And so now the dilemma is to touch or not to touch. And recently, it's been published this nice paper, The Battle of Infertility, in which six opinion leaders just debated and fight one to each other, try to state if the best solution is first doing surgery or first doing IVF. And I will try to summarize the result of this battle, starting that saying informative randomized controlled trials on the comparison between surgery and IVF in infertile women with endometrioma are lacking, unfortunately, and the guidelines are contradictory. On the other hand, the key point to me is a shared and informed decision taken with the patient, with the couple. But when we are talking about infertility, there is a woman with endometriosis and there is a man. So discussion should be done with the couple. But we should be clear and honest, saying to this patient that the chance of a live birth rate after surgery and after one single IVF attempt is almost the same. But there are pros and cons of the two procedures. Doing IVF has got the risk of ovarian hyperstimulation syndrome, the risk of multiple pregnancy that you can avoid just using a single embryo transfer. The cost in some countries are higher, much higher than surgery that is paid by the state, and the risk of the endometrioma infection. On the other hand, doing surgery increases the risk of hemorrhage, organ injury, infection, anesthesia complication, and damage to the ovarian reserve. The coagulation can just create some vascular damage, and there is clear evidence in the literature that every surgery can affect the ovarian reserve, and DMH show this reduction. Again, pros and cons. Doing IVF could be the right solution when there is always a previous history of already surgery. Repeating a surgery could be a big problem and risky. When there is the bilaterality of the endometrioma, in this case, the best solution should be the IVF, again for the risk of deplementing and destroying the ovarian reserve. When there is a male partner condition, this is clear. If there is a reduction in the sperm count, and we need to do an ICSI, that's the only way to do. Women older age, reduce ovarian reserve. On the other hand, if you have a large singular unique cyst or ultrasound suspicious, the surgery could be the right solution. Okay, I have to hurry up, I know. Are hormonal therapy effective as adjunct to surgical therapy? So contraceptive pills, danazol, progestin are useful? No, the answer is no. Not before the surgery and not after the surgery. For infertility reason, it's clear. And I still have some other question in my mind. Does endometriosis affect ART outcome? Does the severity affect ART outcomes? And does IVF has impact of endometriosis? And the literature is quite clear. Yes, the endometriosis affect almost all the outcome for these patients, especially the severe one. If you see the number, if you do an IVF for endometriosis stage 1, 2, the result is comparable to those underwent IVF for tubal factor, and the result in terms of implantation rate is much lower for the stage 3 and 4. Sorry. And on the other hand, if the question is, does an endometrioma per se affect the response to IVF? Maybe the answer is no, not always, I would say. And this study from Laura Benaglia showed that the number of recruited follicles, both little and both more than 15, is similar. And again, the size and number of endometriomas and deep peritoneal nodule does not change after ovarian stimulation. But this is difficult to state because each woman has got his own response to the drugs. And just quickly, do not forget the possibility for patient that should undergoing to surgery with the risk of destruction of ovarian reserve, the possibility of cryopreservation of the oocyte of the embryos or the tissue in case. And last but not least, we should advise our patient that having endometriosis could have some influence also on their pregnancy, because there are data showing that in this patient there is increased risk of preterm delivery, preeclampsia, placenta previa, cesarean section, and need for neonatal admission for the babies. So I just tried to summarize quickly. It's quite a weird disease, endometriosis, with so different manifestations in women. Infertility could be one of the problems affecting these women. The idea is just to make a prognostic approach and not diagnostic approach, so try to find the best way to help these women to have a baby as soon as possible. Surgery can be useful, but should be balanced on risk-benefit together with the possibility to go directly through an IVF to help these women. And again, the key point is to always do a comprehensive and clear information, a rich and informed consent with patient. Thank you.
I think we have some time for questions. Anybody would like to ask? Dr. Pucciarelli? Yes. Please.
Thank you. Professor, it's very high. What about the Visan, the role of Visan after endometriotic surgery?
Well,
Mine is very high, yours?
No. As I stated before, we are talking about the problem of infertility. Different things is when you're talking about the use of drugs, therapy, to avoid the recurrences or to avoid the comparison of pain again. So for infertility, it doesn't work. It doesn't make sense. It's just a matter of delay the time to pregnancy. If it's done for other purpose, perfect. I agree. I use it anyway. Or I understand the use of Visan or any other danazol or contraceptive pills for a short period of time, 3-6 months, but not longer, for conceptual problems. Yeah. For other problems, you can use it and it's useful.
Yeah. So now, how many months or years after surgery, if you are not using it for infertility, using Visan?
Well, it depends on the age of the women, how long they are looking for a baby, if there is
No, if it's not for infertility, it's just for the symptoms and recurrence of endometriosis.
Well, if it's not looking for a baby, you can use it for years. I mean, there's some concern about the problem connected with the osteoporosis, but the last results say that there's no risk. So can be used for how long you need it. If it's not for infertility, of course.
Thank you.
You're welcome.
Yeah. Yes.
The size of the endometrioma, does it make any difference for you to pose for IVF or surgery?
Well, it's the size together with bilaterality. If there is, usually in literature, endometriomas bigger than 5 centimeters could be considered for surgery, especially if they are monolateral. If you have even bigger but bilateral, I will do an IVF before. I understand that sometimes doing IVF with too big endometrioma is complicated. The retrieval could be risky, but the literature is clear that if you take out too big endometrioma or two endometriomas by both sides, the reduction in terms of the ovarian reserve is higher. The MH goes down, fall down.
Do you recommend aspiration of the endometrioma when the ovum retrieval at the time?
During the retrieval? No, I would never do that. For the risk of peritonitis, chemical peritonitis, and for the risk of affecting the quality of my eggs retrieval before, so toxicity.
Any more questions? Yes, Dr. Farah. Again.
What about the use When about the use of GNR analog before surgery? Is it
For the GNRH analog?
yeah, before surgery?
Well, the data are conflicting, but there are some data, again, not for infertility itself, that can be useful.
Can be useful.
3-6 months before.
3 to 6 months.
Yeah,
Thank you.
you're very welcome.
Okay, now we move to the next session. Thank you, Dr. Bucciarelli. Our next speaker is Dr. Abdulaziz Al Obaid. Dr. Abdulaziz is a consultant gynecological oncology. He is the CEO at Care National Medical Company in Riyadh. And he's going to talk to us about a very important subject in fertility, which is fertility sparing in oncology patients. Thank you, Dr. Abdulaziz. Please.
Thank you so much. It's a pleasure and an honor to be with you, and I would like to thank the organizers for their kind invitation. So, recently there's been an enhancement in the survival of patients with cancer, and the science of reproductive medicine and oncology have developed a lot in the past few years. And because of that, we see more women cured from their cancers. Oncofertility is the discipline, the interdiscipline that refers to preserving the fertility options to women. And it has to be a combined effort between the reproductive endocrinologist and the oncologist. Because about 10% of women will have cancer before the age of 40, which is a significant problem. In this presentation, I'll be talking about the options that women do have for fertility preservation. So the most important thing is that all women with potential interest in keeping fertility should be referred to a fertility unit. And if that's my only take-home message that you get, then I think I have accomplished a lot. These patients have to be referred. You have to speak to the oncologist. You have to tell them that you have options. We don't see patients with lymphomas. We don't see patients with leukemias, and they get cured. We see them later on after they get cured, and they live miserably because they cannot reproduce. Since several patients and treatment-related factors are associated with the risk of developing infertility, the counseling is tailored upon the patient condition. So depending on the kind of therapy that you will get and the kind of intervention that we will offer. And as a gyne-oncologist, we should always wear two hats. It's not only enough to cure the patients from their cancers, but we have to consider their fertility options. I remember speaking to the medical oncology team more than 10 years ago. I went to present for them about the GnRH agonist role of protecting the ovaries and the fertility preservation, and they were looking mainly into patients with breast cancer. And I had a huge resistance because they were worried about the delayed fertility, the effect of GnRH agonists on the breast cancer, and one of them shocked me by saying, all I care about is that the patient should live and be cured of her cancer. Well, that's what you care about, but is this really what the patient wants? We have to be the patient's advocate. What is very concerning is that 95% of men who have cancers, they get referred for sperm cryopreservation. But when it comes to women, the data is variable, but it can be as low as 2%. 2 to 65% of women are referred to a reproductive center. And that's very alarming and concerning. So the options that women have: egg collection and freezing, embryo development and freezing, ovarian tissue freezing, ovarian transposition, radiation shielding, and ovarian function suppression with GnRH agonist. I'm going to start with the last one. This is the toxicity of some of the treatments to the ovaries. The most toxic treatments are the radiation therapy, especially with cervical cancer. We use 8,000 rads. Well, the toxic dose to the ovaries is 1,500. So for sure, if we don't protect the ovaries, they're going to be damaged. And the alkylating agents, especially above the age of 35. So the role of GnRH agonist, the ovarian suppression with GnRH agonist during chemotherapy should be considered as a reliable strategy to preserve ovarian function and fertility. At least in breast cancer patients, the data have been reassuring that there is no detrimental effect on these patients. And recent meta-analysis shows that there is a 57% reduction in the risk of ovarian failure, a huge reduction with simple treatment. In the Cochrane review, GnRH agonist did appear to protect the ovarian function, resumption of menstrual function. However, because of the low number of cases that were identified, the pregnancy rate could not be shown in randomized controlled trials that it has increased. This is a paper that was published in the New England Journal a few years ago in 2015, and it's randomly assigned patients who are going to have chemotherapy, either to receive GnRH agonist or not to receive GnRH agonist. And the results are impressive. The ovarian failure was 8% in the GnRH agonist group and 22% in the chemotherapy group, and that was statistically significant. Over 200 patients, so 218 patients who could be evaluated. Pregnancy did occur in more women in the GnRH agonist group than the group with the chemotherapy alone, 21 versus 11%. Interestingly enough, there was also improved survival, probably related to low estrogen levels. So how does it work? When I teach the residents, I tell them chemotherapy work on rapidly active cells. So you get nausea, vomiting from the GI tract, you get hair loss, you get bone marrow suppression. The ovaries, we have follicles coming up every month. So switch them off, put them to rest, it will be immune to chemotherapy. So the possible protection of ovarian germ cells in the presence as a presence in the ovary of germ line stem cells with mitotically active, able to reconstitute in the primordial follicle. The presence of elevated level of estrogen will be reduced. Elevated estrogen will increase the perfusion, blood perfusion to the ovaries, and that leads to more chemo delivery to the ovaries. Reducing the estrogen will reduce the blood supply, less chemotherapy going to the ovaries. And it has been observed that the GnRH receptors are expressed in the ovarian surface, and their activation may result in the reduction of apoptosis. These are some of the guidelines. I'm going to skip some of the slides because of the time. I'm going to switch gears now to cervical cancer. And before I go there, by the way, we were lucky enough to convince the oncologists at our center for adopting the GnRH agonist. And the key success was a reproductive endocrinologist. She accepted to see all the patients on the same day of referral, and she has developed a protocol, guidelines on how to start this treatment. So I do encourage all of you to think seriously of that. With cervical cancer may affect women. They may, the standard treatment for patients with cervical cancer when A2, 1B1 is radical hysterectomy. So especially if she's a young patient, basically she would lose her uterus. A huge advancement has been accomplished in the past 20 years where radical vaginal trachelectomy, it was first published by Obrel, and then it was made popular after Daniel Dargent published his experience with radical vaginal hysterectomy and laparoscopic lymphadenectomy. The idea is to remove the cervix, upper vagina, the parametria, and to do lymph node dissection laparoscopically. At the end of the procedure, a cerclage will be placed because if you don't have a cervix, then there's a huge risk of preterm deliveries. Since the initial reports, huge data were published, summarizing over 700 patients. Al Covens and his colleagues, they published that the oncology outcome, the recurrence rate was 4 to 5% with a 5-year survival of 97%, which is equal to the standard arm of treatment, which is radical hysterectomy. So basically what we do is just remove the cervix, the lower part, and then put a cerclage at the isthmus. There was a concern about adenocarcinoma, whether this procedure should be done. The majority of patients have squamous cell carcinoma, 75% of the patients, but studies have shown that it's really not the type of the cancer, but rather the location. And because adenocarcinoma can be high up in the cervical canal, that's why there was a concern of recurrence, and if it's low, then it's probably a suitable procedure. When comparing the radical vaginal trachelectomy with the traditional radical hysterectomy and lymphadenectomy, the recurrence rate, as mentioned before, was found to be similar, 5.8% for radical vaginal trachelectomy versus 4.4%, which was not statistically significant, and the survival was 97% in both groups. And the significant recurrence in the vaginal trachelectomy group was related to the size of the tumor. So patients with tumor more than 2 centimeters are probably not the best candidates, although neoadjuvant chemotherapy have been used to shrink the tumor and then perform the procedure. The complication rate appeared acceptable and similar to the radical hysterectomy group. However, 15 patients have unique dysmenorrhea because of stenosis. Over 250 pregnancies occurred, which have resulted in over 100 live births. And for those who attempted to conceive, 40 to 79% were able to achieve pregnancy, and the spontaneous miscarriage in the first trimester was similar to the usual controls, the normal population. However, the risk of preterm delivery and second trimester miscarriage was higher. Radical abdominal trachelectomy, it can be used, and it has been used especially in the pediatric agents group. So if you don't have access to the tumor vaginally because of the patient age, then it's better to perform the radical abdominal trachelectomy. And especially for tumors more than 2 centimeters, probably the best thing is to do radical abdominal trachelectomy. For areas in the world, like in my region, in your country as well, where we don't have enough cases of early stage cervical cancer, if you don't have enough experience with the radical vaginal trachelectomy, it's easier to do radical abdominal trachelectomy. And it's basically the same concept. It's like doing the radical abdominal hysterectomy, developing the spaces, chopping the cervix off with the upper vagina, and placing the cerclage at the same time. I'm going to skip some of the slides because of the time. Now, cone biopsy for 1A1, tumors less than 1A1, the chance of lymph node metastasis is practically zero, so they can be cured with cone biopsy, but they have to have vigorous follow-up. And even with just cone biopsy, you have an increased risk of preterm delivery, so you have to balance your size of the cone. It's not only that women should get pregnant, but preserving the ovarian function is important to, the whole well-being of women. And as I mentioned, if you give radiation therapy for patients with cervical cancer, for sure the ovaries will be damaged. So what we can do is do the ovarian transposition before the radiation therapy. Laparoscopically, it can be done. It should not delay the treatment. So basically the ovaries are hitched up and attached to the anterior abdominal wall and removed out of the radiation field. And even in the future, egg collection and embryo development can be done for these patients. Now, this may not be applicable in countries like mine and yours, where we don't have surrogacy, but it is an option for other countries. So basically, the uterovarian ligament is transected, the ovary with its blood supply is maintained and hitched and sutured up to the anterior abdominal wall. You will see more patients with endometrial cancer, young patients with endometrial cancer who wish to preserve fertility. We have higher incidence of obesity. These patients are usually identified in the reproductive endocrinology clinic before starting the treatment. For menorrhagia, PCOS, they would do an endometrial biopsy, and for their surprise, it's an endometrial cancer. Now, once you have this in a young patient who never had children, it's a serious issue. But what's good about this is that most of these patients have grade 1 tumors, so well-differentiated tumors that can be cured. And almost all of them, they have polycystic ovarian syndrome. The use of progesterone in treatment of stage 1A endometrioid adenocarcinoma without myometrial invasion is well established, although the number of patients reported are low, because in any center you won't have a huge number of patients. A major problem with endometrial cancer staging is that you have to do the hysterectomy and bilateral salpingo-oophorectomy, possibly lymph node dissection to identify the correct stage. But you can omit this if you do if you do the MRI, which will show you with a fairly good reliability the degree of myometrial invasion, if any, and the lymph node status in 1A1 is most probably with a normal PET-CT is going to be normal. Various remedies reported in the literature: the medroxyprogesterone acetate, 400 to 800 milligram, the Megaze, 160 milligram, up to 320 milligrams daily, or the Mirena. I prefer to use the Mirena, and this is what I use usually. The last patient I treated was last week. She came to me with endometrial cancer, recently married, having menorrhagia, endometrial biopsy showing grade 1. She was referred to an oncologist who told her, your only option is to do a hysterectomy. So the MRI was normal. I did a hysteroscopy. There was a polyp. I removed it. Most probably the tumor was at the surface of the polyp. And I inserted the Mirena. I'm still waiting for the histopathology results. How long? When should you stop the treatment? How often should you assess? There's no good data to support any recommendation. However, the minimum treatment should be 6 months. And I usually repeat the endometrial biopsy every 3 months. And once I remove the Mirena, and before starting the fertility treatment, I would repeat the endometrial biopsy, making sure that there is no recurrence. Response rate is quite good. 75% of these patients do respond. Those who do not respond, you may have to increase the dose before deciding that it's a failure. The recurrence rate of the tumor is 23%, which is quite high. However, that's why they should, after finishing the treatment, complete their family and then offer the hysterectomy as the definitive treatment. So it's really just a temporary treatment to delay in time so that she can get pregnant. And once she gets pregnant and have her baby, then you have to do the completion hysterectomy. And these patients, as I mentioned, they usually have polycystic ovarian syndrome, so I usually refer them immediately once they respond and the biopsy is negative to a reproductive endocrinologist who can start their treatment for her to get pregnant. Good number of patients have been, they had live births. 89 live births have been recorded in 278 patients. Remember, this is not your normal population. These are patients with delayed fertility, most probably. And with the pregnancy outcome, there is no difference for these patients other than the normal population. What's interesting is that some people do offer hysteroscopy. I usually do it. So hysteroscopy evaluation of the cavity. Sometimes you may see the tumor and you can resect it using the hysteroscope. However, there's a concern that if you do this resection, how deep should you go? Will this affect the future placentation and pregnancy, as well as the historic concern of hysteroscopy in endometrial cancer, where you use fluid media, you may disseminate the cells into the peritoneal cavity. It is true that the chances of having positive cytology is higher. However, it's not part of the staging anymore, and the impact of that on the survival has not been demonstrated to be of a major concern. This is a paper from Falconi in Italy, where their routine, this is a prospective follow-up of their patients. Their routine is to do a hysteroscopic resection and before starting the hormonal therapy. And they have excellent results, where the complete response rate was 96%, and the recurrence rate was 7.6%. So 85.7% of patients had durable complete response with a median duration of 95 months. The pregnancy rate was also very impressive, 93.3% for patients who tried to conceive, and the live birth was 86%. The problem is that they have small numbers, and of course in any center you won't have huge numbers, so only 28 patients were treated using this protocol. To me, this is one of the magical drugs. I don't have any conflict of interest, but I always put these patients on metformin. Metformin was associated with a reversal of atypical endometrial hyperplasia to a normal endometrium and decreased the cell proliferation biomarker staining from 51.9% to 34%. Even in cancer patients, endometrial cancer patients, metformin had a higher overall survival compared to non-metformin users. Recent review suggested that adjunct metformin treatment may assist in the reversal of atypical hyperplasia to normal endometrial histology. However, there are no prospective randomized controlled trials. I have to be faster. The epithelial ovarian cancer, young patients who present with epithelial cancer, it's a much more heterogeneous group because you have different types of cytology, histopathology, and patient characteristics. Although the number of series is not known, but recent review of 9 studies with over 500 patients who underwent fertility-preserving surgery showed that the chance of recurrence is 10% and the chance of death is 5.5%, which is similar to the historical control. So the fertility preservation surgery is an absolutely viable option for patients with stage 1A, grade 1 to 2. And patients with endometrioid adenocarcinoma, you have to sample the endometrium. The standard treatment is debulking surgery, so you have to remove everything, but with early stage disease, you don't have to biopsy a normal looking other ovary, although there is a concern that there might be microscopic metastasis. Currently, the European Society of Gynecology Task Force, they recommend stage 1A, grade 1 to 2, and possibly grade 2 tumors are suitable for fertility preservation. The concern is the patients with 1C, not those who have intraoperative tumor rupture, but positive cytology or tumor on the surface, and the high-grade types, but it has been tried as well. It has to be highly selective and with proper counseling. Borderline tumors, these are common tumors. You see them usually in the younger age group. Most of these patients are diagnosed during their fertility, reproductive age. They usually are treated with conservative surgery, so salpingo-oophorectomy is enough. You don't have to sample the other ovary. And the prognosis depends on this, the invasive implants, whether they're invasive or not. So it's not really the stage, but rather the type of implants. And studies have shown that there's a good outcome. Do you need to do a completion hysterectomy? Definitely it would reduce the chance of recurrence, but even if you have a recurrence, it's usually borderline, so it's very easy to salvage them. I usually don't do a completion hysterectomy. This is the typical borderline tumors. This is, sometimes you can be fooled if you look at it. I had a patient with bilateral tumors, and this is what it looked like. And you know, your initial gut feeling is that this is probably cancer, it's concerning. And she vigorously expressed that she does not want to have her ovaries removed unless it's cancer. This was a benign serous cystadenophybroma, and we were able to preserve the other ovary. The germ cell tumors, younger patients, sometime in the childhood age, these patients are the best candidates for conservative surgery. You have to preserve the uterus and the other ovaries. Most of these tumors tend to be unilateral. Even with advanced stage disease, these tumors are very chemosensitive, so even in stage 3, you can preserve the fertility for these patients, and chemotherapy can cure these patients. This is a very impressive paper with results showing that over 90% of the survivals became pregnant. And in these patients, in this study, they have patients with stage 3, 8%, I think, 5% of patients. And 2 patients had recurrence. 6 years recurrence after the initial treatment, and peritoneal dissemination spread, treated again with chemotherapy, got pregnant. So with these patients, please be very careful before doing a radical surgery. The storage of oocyte and embryos, always refer patients, especially if the tumor is not impacting the ovaries, where the fertility physician can counsel the patient, do a oocyte retrieval and freezing. I have an excellent relationship with the fertility specialist, and we cannot work in silos. We have to build the relationship for the better outcome of the patients. Oocyte cryopreservation. Again, I'm running out of time. So I'm just going to skip some of these slides. There is no concern about the impacting the outcome to the cancer patients. So even if you give a short stimulation protocol, the breast cancer patients are not impacted. These are the patients who may have tumors that are sensitive to estrogen. So I think I'm going to stop here to allow some time for questions. Thank you.
Thank you so much, Dr. Al-Obeid, for your comprehensive presentation. Unfortunately, we have time only for one question from the audience. Only one, ladies, I'm sorry.
Thank you very much for this informative presentation. I agree with you, this part of fertility sparing and fertility preservation in this area is really lacking. Majority of I will not blame the gynecologists, but even the oncologists, they don't refer those cases early for, for discussion and the counseling. My question, do you have, objection for, for the period? When do you advise we start after the ovarian surgery? That's one question. Number 2, the endometrial cancer. Especially we see a lot. In Bahrain, based on a local study, 1% of those infertility, they have a tibia. We have this, we've done a prospective study. Unfortunately, it was not really yet published, but we have 1%. And we usually give them Mirena. But Marina, so when you do the biopsy and it's negative, I don't see any objection. We can start while Marina is in. Do you have any objection? So I have two questions, the ovarian and the...
So the question, when can the patient seek fertility after?
No, we will see them early. This is I prefer that I see them very early, so it will be they will have a time for the counseling. But for the ovarian cancer, when you say you do the surgery,
Yeah, so when we
do you have any objection of starting them straight away before starting the chemo?
Yeah. You have to individualize. If she's a young patient, let's say she's 20, 22, I would prefer to wait at least a couple of years to make sure that she's fine and she won't get recurrences. If she's a 38 years old patient, probably I would be in a rush, and after 1 year, maybe she can start the counseling, the workup, and the treatment. So the ideal time is to wait for 2 years, because most of the recurrences happen first in the first 2 years. Yet you have to individualize. And for the hyperplasia, I didn't understand your treatment. Your question. The question is when to start.
I'm talking about the atypia.
Yeah.
Even hyperplasia, I do usually put Mirena and then I start, because this is the recommendation or the guideline. So if you have an endometrial hyperplasia, you have to, shorten the period to pregnancy because of the recurrence of the hyperplasia. But I mean for the atypia, when you put a Mirena and you do the biopsy after 3 months, if negative, do you have any objection for me starting away my fertility?
No, I would remove the Mirena. I would wait for at least 2 months and repeat the biopsy and make sure that the patient will not get a recurrence when she's off treatment. So before starting the fertility treatment, repeat the biopsy, make sure that she's negative and she does not have the recurrence of the treatment. And then if it's negative, I have no objection. In fact, I would like them to complete their family.
I mean, usually when we put Mirena, I'm talking about the experience. We usually put the Mirena and we stimulate the ovary because of those fertility preservation freezing. So we can accumulate the eggs and freeze them for future use. So we are not really replacing the embryos until we have a negative endometrial biopsy. To shorten, especially for those cases, I'm talking about cases where the ovarian reserve is very low. So they are old and their ovarian reserve is really low. They don't have really the time,
But my problem here is that you're giving progesterone and then you're increasing the estrogen. So yeah. I'm not sure if it's appropriate to start the stimulation right away.
No, I'm not starting with the positive. I'm starting with the negative while Mirena in.
When it's negative, then
when it's negative, yes.
Take it out.
I don't take it out because, as you said, you have to repeat it again. That's my question. Because you said you have to repeat it again, even if it's negative.
There are no clear guidelines.
Start at 3 months. Sometimes they don't have this 3 months.
I would take it out if it's negative, because even the impact of Mirena may, take some time to reverse the endometrium to build up again, and it's going to be atrophic and thin, and it's going to be an issue for you for the embryo transfer. So.
I don't do the embryo transfer when Mirena is already in, or even after.
Oh no, I know, but I
give it a time for that.
I wouldn't start the stimulation. Take it out, repeat the biopsy, then do the whole thing immediately.
Thank you very much. Thank you again for your presentation.
Thank you.
Now it's my pleasure to introduce the next speaker. This is Professor Anthony Dempsey. Professor Dempsey is Associate Professor in Obstetric Gynecology here in Bahrain and is member of the Royal College of Surgeons in Ireland. Please, Professor.
Good morning, everybody. You're all very welcome. I'm Anthony Dempsey, and I represent RCSI Medical College here in Bahrain, and I'm from Ireland. And I'm most grateful to the organising committee for asking me to present on primary ovarian insufficiency. Sorry. And a summary of which is on the slide in front of you. I hope to discuss some of the causes of primary ovarian insufficiency, which we used to call premature ovarian failure, as well as discussing the clinical consequences of estrogen deficiency, and then the clinical management of the problem. Obviously, the natural menopause is a retrospective diagnosis of 12 months of amenorrhea, occurring in 90% of women between the ages of 45 and 55, with an average age of 51. Early ovarian aging, women who have the menopause between the ages of 40 and 45, almost 10% of the population. And these are women endowed with a lower ovarian reserve than their peers, as well as having early accelerated follicle loss. Normal follicle loss tends to occur around the ages of 37 to 38, and in these ladies it occurs around the age of 32 to 33. Primary ovarian insufficiency is a diagnosis made on the cessation of menstruation for at least 3 months in women under the age of 40, and is associated with high levels of FSH and low levels of estradiol. Its prevalence is about 1% of the population under the age of 40, 1 in 250 women under the age of 35, and 1 in 10,000 girls under the age of 20. The etiology is multifactorial, and I just thought I'd highlight some of them. Genetic causes, Turner syndrome 45XO is the commonest chromosomal defect in humans, and it occurs in about 1.5% of conceptions, 10% of spontaneous miscarriages, and 1 in 2,500 births. As you know, it's associated or presents with primary amenorrhea, usually, with absent secondary sexual characteristics, and is associated also with serious morphologic defects. Turner mosaicism is 45XO with 46XX as well, and these women have normal development. They have no morphologic defects, and they tend to present with early secondary amenorrhea. I should mention the Fragile X syndrome premutation carriers because its prevalence is 2 to 5% in women who present with POI, and 12 to 14% in women who have a family history of POI. And up to 28% of these women, these carriers, will develop POI. So it's recommended that if a diagnosis is not clear in a woman with POI, that she should be screened for Fragile X syndrome. Autoimmunity was first postulated as a possible cause when it was found that some women with adrenal insufficiency also had ovarian insufficiency. And about 4% of women with POI, this may occur as a multi-endocrinopathy syndrome, where there's autoantibodies to multiple endocrine organs as well as non-endocrine organs. And if there's a family history of autoimmune disease, then this should be sought. The histologic evidence that POI is secondary to autoimmune enteritis is mediated by an intense lymphocytic infiltration of theca cells, with both the primordial follicles and granulosa cells are spared. On the left is type 1 syndrome, which is usually it occurs commonly in children and is associated with hypoparathyroidism, mucocutaneous candidiasis, and adrenal insufficiency. And I came across a young girl back in 1979, I have to tell you, who had this particular complication. The type 2 is usually associated with adrenal insufficiency, autoimmune hypothyroidism, and type 1 diabetes. And as the previous speaker, Dr. Abdulaziz, has mentioned, there are increasing numbers of young women and girls surviving cancer. And they will often present with POI because of the complications of chemotherapy and radiotherapy. Surgery has been implicated as well. Hysterectomy, women tend to have an earlier menopause following a hysterectomy, and some have implicated uterine artery embolization. I raise the issue, I haven't come across it in the literature, but if we're dealing with a woman with a massive postpartum hemorrhage in whom we're considering doing a peripartum hysterectomy, the RCOG guidelines in the UK recommend a stepwise devascularization of 1 or 2 of the uterine vessels and 1 or 2 of the ovarian vessels. This could lead to a compromise in the ovarian vasculature, obviously, and I suspect that many of these ladies may present at a later date with primary ovarian insufficiency. We're aware also that males who develop mumps may get mumps orchitis and possible testicular failure. It has been presumed that this occurs in women, but apparently it's not quite documented as well as in males. We had a young lady in 1980 at 14 years of age. She had 2 periods, following which she had a severe dose of mumps, amenorrhea thereafter, and presented to our clinic at the age of 18. And she had premature ovarian failure, as we called it, at that time. Unfortunately, a considerable number of patients were not able to find an explanation for their ovarian insufficiency. So in relation to the clinical consequences, they're based really on a deficiency of estrogen. And initially, of course, there's a menstrual pattern disturbance with patients presenting with oligomenorrhea, but usually amenorrhea. They may or may not have vasomotor symptoms and may complain of vaginal dryness and dyspareunia. Of importance, of course, is that these ladies may be at increased risk of cardiovascular morbidity and mortality. And this is possibly related to vascular endothelial dysfunction, and this can be restored to normal with estrogen therapy. POI patients are also at high risk of osteoporosis, particularly young women who have yet to attain adult peak bone mass density. The other complications are, of course, and would be of great concern to both the young girl or woman and her husband or her parents. Infertility would loom on the horizon for them, but there is intermittent ovarian function which occurs spontaneously. They may be at risk of reduced neurocognitive function, as well as diminished sexual well-being and emotional health. So the diagnosis is based on a triad of amenorrhea or oligomenorrhea associated with elevated levels of FSH. These should be repeated on 2 occasions, at least 4 weeks apart. Estradiol levels are very low, and the patient, as I said, may or may not have symptoms or signs of estrogen deficiency. The importance of early diagnosis I've outlined in one sense, in that the attempt is to try and prevent the development of osteoporosis and prevent the later development of coronary heart disease. Unfortunately, in one study, there was a 5-year delay in making the diagnosis in 25% of these young women. And more than 50% of these women had seen 3 or more clinicians before this fairly simple diagnosis was made. So it's recommended that any woman who has normal, regular cycles and who presents with a minimum of 3 months of either oligomenorrhea or amenorrhea, they should be evaluated by simple laboratory testing. Once the diagnosis is made and pregnancy has been excluded because of the amenorrhea, patients should have some additional investigations. This would include screening for adrenal insufficiency and hypothyroidism. It's also recommended that women should have a karyotype done, as many will have an abnormal chromosomal analysis. If there's a family history of POI, then they should be screened for the Fragile X syndrome. And I think it's critically important that at the diagnosis, we should do a DEXA scan, as 50% of these women will have either osteopenia or osteoporosis. And a transvaginal ultrasound scan may be helpful in diagnosing bilateral ovarian enlargement due to autoimmune oophorytis. In terms of management, of course, it's related to estrogen replacement therapy, but I'm very much impressed by the fact that over 70% of patients complained at the manner in which they were informed of their diagnosis and the time they had to spend with their clinical team. This is a critical component in these patients' lives and their families. And so their emotional health is very much at stake, and many of them do develop both depression and anxiety disorders. So referral to a therapist with expertise is very, very helpful. And of course, providing accurate information in relation to their long-term management, as some of them will have intermittent ovarian function, and some may achieve a pregnancy spontaneously. Unless absolutely contraindicated, estrogen is critical for the management of these ladies. And the estrogen-progesterone regime should try and mimic normal ovarian function if possible. In this regard, 17-beta estradiol and micronized progesterone have been recommended. And the optimal replacement depends on whether the patient presents with either primary amenorrhea or secondary amenorrhea. If the patient presents with primary amenorrhea and the absence of secondary sex characteristics, then the estrogen provided should be initially very, very low in order to mimic gradual pubertal development. I've mentioned 6.25 micrograms per day here on this slide. Others would suggest an even lower dose. The estrogen can be increased on a 6-monthly basis until it reaches a maximum of about 25 micrograms a day. After 2 or up to 3 years of this kind of treatment, then micronized progesterone can be added into the equation, provided there's substantial breast development. This, of course, will give rise to regular withdrawal bleeding. Full replacement therapy can be given to those who present with secondary amenorrhea. And this can be done either with transdermal patch or an estradiol vaginal ring, and the dose I mentioned here. These routes are more physiological than oral routes of estrogen replacement, in that they go directly into the systemic circulation, avoiding hepatic metabolism first, and therefore reduce the incidence of the risks, I should say, of venous thromboembolism and gallbladder disease. The doses are higher than the usual doses of estrogen therapy for postmenopausal women and equals the average daily production of estradiol by the premenopausal ovary. Progesterone, there's an option here of micronized progesterone, and some say medroxyprogesterone acetate. These are both given from the first 12 days of each calendar month, therefore ensuring regular withdrawal bleeding. I think most would probably opt for the micronized progesterone, as it seems to have less effects on lipids and coagulating factors. And the American College of Obstetricians and Gynecologists recommends the combined oral contraceptive pill, where contraception is important. Other benefits, well, there's an increased sexual function and an improvement in emotional health following the introduction of estrogen for these girls. You can well imagine how traumatic the diagnosis is, but with the development of secondary sex characteristics, regular withdrawal bleeding like their peers, they can gradually come to terms with the long-term complications that they're presented with. So the duration of therapy is recommended to go to the average age of menopause, which is 51 years of age. And this, of course, prevents the acute symptoms of estrogen deficiency, as well as providing the benefits of long-term health. More than 50% of patients, in one study, more than 50% of patients with POI had either never taken hormone replacement therapy, had spent years following the diagnosis before they started on therapy, or discontinued this prematurely, either on their own volition or on the advice of their clinician. Obviously, for older postmenopausal women, there's the benefits of osteoporosis prevention is there, but there are concerns following the Women's Health Initiative published in 2002 that long-term estrogen might include cardiovascular complications and an increase in breast cancer. Indeed, following that, there was a significant reduction in women, older postmenopausal women, taking hormone replacement therapy. I think it should be emphasized to these young women with POI that they differ from their older postmenopausal ladies, and that they are at greater risk of cardiovascular problems, overall mortality, and cognitive decline with estrogen deficiency. And as I mentioned, several studies have suggested that POI is associated with a vascular endothelial dysfunction, which, if you like, is an early marker for atherosclerosis, and that this is reversed using estrogen therapy. So this is a balance, if you like, a benefit-risk balance using transdermal estradiol with micronized progesterone. There are no increased risks of breast cancer, stroke, thromboembolism, or gallbladder disease. And of course, the benefits are there. There's an improvement in the quality of life. There's cardioprotection. There's the protection from osteoporosis and osteoporotic fractures. So there are other principles in relation to bone health would include exercise. Weight-bearing exercise is important, and 25% of these young women have no exercise regime. And of course, a healthy diet. So I know nothing about dietary control or exercise for that matter, so I would involve the professionals, the dietitian and a fitness expert. They should avoid smoking. And also, they're advised, as many of these women have inadequate vitamin D intake and an inadequate calcium, so they're advised to take these supplements in order to help with bone health. In relation to androgens, we know that women produce androgens from both the ovary and from the adrenal gland. So women with POI have reduced ovarian androgens. Unless they have coexisting adrenal insufficiency, their adrenal androgens will be normal. There's been no real studies done on the consequences of this reduction in ovarian androgens, but the available data suggests that testosterone or androgens are not really beneficial, and therefore they're not recommended on a routine basis unless the woman has coexisting adrenal insufficiency. In that case, they could be added. Or she may have a significant reduction in libido, and in which case a trial of androgens may be added to her regime. Of course, there are side effects such as hirsutism and acne, and sometimes virilizing symptoms. So in terms of endocrinopathy, 4% of women POI will have asymptomatic autoimmune adrenal insufficiency, which is potentially fatal. The lady I mentioned back in 1979 almost died on the operating table having her appendix removed. Subsequent investigations revealed she had adrenal insufficiency and amenorrhea, and she was referred to our clinic where we diagnosed premature ovarian failure. Adrenal antibodies should be done, and if they're there and present, they should be evaluated on an annual basis, as 50% of these patients may develop adrenal insufficiency. Similarly with hypothyroid antibodies. I won't go into the chemotherapy, as we've had a very good account of the management from Dr. Abdulaziz and the previous speaker. In terms of contraception, and obviously the combined oral contraceptive pill has been advised, and in relation to infertility, the options to these patients are to a certain extent limited. Spontaneous ovulation may occur between 5 to 10% of patients. Induced ovulation has not been very helpful with either estrogen or with gonadotropin therapy, glucocorticoid therapy, or gonadotropin with GnRH agonist. I'll be just finished in a moment. And however, there has been some success with suppressing endogenous high levels of FSH-LH with estradiol before and during gonadotropin stimulation of ovulation, about a 32% success rate in a very small study. These patients are candidates for in vitro fertilization with oocyte donation, and the success rate in oocyte donation depends primarily on the age of the oocyte donor. The younger the age of the oocyte donor, the higher the success rate. So those over the age of 35, there is a significant decrease in the success. Adoption is, I think, quite uncommon in the Middle East. There's a reduction in the number of babies available for adoption, both in the UK and Ireland, and it's a pretty arduous and very invasive process to go through. So, in summary, I just want to give some practical recommendations. I think we should improve the awareness amongst young women who are having regular menstrual cycles, that if they do develop a menstrual irregularity, they should seek attention promptly. The majority of these will be related to functional hypothalamic amenorrhea, related to either dieting and weight loss, stress, or vigorous exercise. But I think we should do a simple biochemical test to rule out POI. We should improve the efficiency and the knowledge amongst our clinical colleagues so that they will investigate these patients promptly, and early institution of effective treatment, appropriate duration of this treatment will improve the quality of life and long-term well-being for these patients. Early referral to our specialist services in reproductive endocrinology, in the infertility services, as well as our psychological colleagues. And ongoing monitoring is essential. Thank you very much indeed for your attention. Thank you.
Thank you so much, Professor Dempsey, for your clear and elegant presentation that is now open for discussion.
Yes, Doctora.
Good morning. In a patient with premature ovarian failure in young patients, we know if you continue replacement therapy, there is a risk of breast cancers and other risk.
I'm sorry, my hearing is not great. I can't really hear you, sorry.
In a patient who's been diagnosed with premature ovarian failure, yes. You can hear me now?
Yes.
Okay. In young patient, in young populations, because we see actually in the clinic patients who have primary amenorrhea and they will have some sort of primary ovarian failures. We will start estrogen replacement therapy for them, but usually will be concerned because he has to continue this patient on long-term therapy.
I'm sorry, is the question, how long do you continue the therapy?
No, I'm not asking about how long you continue. We usually start this treatment for long-term. But there is also concern about breast cancer.
Yes.
So how we can go, because they need that sort of treatment.
In terms of cancer, I think the therapy should start usually around I count the lights in my eye, it should start around the ages of 12, and it's on very, very low doses. It's just to mimic pubertal development and gradual pubertal development. And then there's an introduction of micronized progesterone to ensure that the patient has regular withdrawal bleeding. I'm not too sure I understand the question.
No, actually I'm asking about the concern of breast cancer in this sort of patient because they will receive long-term of estrogen replacement.
Yes. Well, I think there's been, certainly in patients with Turner syndrome, there are 62 patients followed for 20 to 40 years on estrogen replacement therapy, and there was no case of breast cancer reported in that group. So there does not appear to be an increased risk of cancer with these patients, to my knowledge.
Okay, thank you.
If I get something just on these topics, it's totally different when you think about the replacement therapy after menopause. It's totally different things to give the hormones to a patient that are supposed to have hormones in this period of life. So we're not so worried about the risk of breast cancer in these patients.
Doctora Farah, okay.
Good morning, sir.
Good morning.
What about stem cell treatment for these young women with premature ovarian failure? Is there any trial given to them?
I haven't come across, in looking at the literature, I haven't come across that.
Thank you very much for your presentation. It's just a case I want to share with you. A patient who presented with primary amenorrhea, and then karyotype came as mosaic, Turner as XY. So she's Turner and XY, mosaic Turner. So mosaic Turner 40X, XY. As a Turner, so she's mosaic, so she's carrying as a Turner, and then the other chromosome is XY. What is your recommendation as a follow-up?
I'm sorry again.
It's
not so much the volume. I think it's my ears.
Okay, she's a mosaic Turner XY.
What will be your management of a lady with mosaic Turner syndrome?
Mosaic.
Yep.
Okay. Well, they tend to present later, obviously, with secondary amenorrhea, but also I would use estrogen replacement therapy after they present. I don't think there will be any difference. Can I talk to you about this afterwards? It's unsatisfactory at the moment for me, I'm sorry.
I think you can discuss this over coffee, I think, this question.
Is that okay?
Yeah.
I'm very sorry.
It's all right. I think the question is not very clear. Any other questions? Yes, this lady.
Dr. Kiran.
Doctor, I think there's some countries which are doing screening at birth for bar bodies with the saliva, with a buccal swab.
I haven't come across it in the literature, no.
Yeah.
I guess one of the things that could be done in women in whom you might suspect it, or if there's a strong family history, would be to do the AMH, the anti-Mullerian hormone, to measure ovarian reserve. But, and sometimes this is done in young girls with Turner syndrome, but I haven't come across what you've just mentioned, no.
Yeah, there are some countries which are doing screening for bar bodies at birth.
Yeah.
And then they have, because till the age of 7 or 8 years, they actually have follicles.
Yeah.
They actually have germ cells.
Yes.
And after which, actually, the deterioration starts.
Yes.
So they try to do some measures before that age.
Mm-hmm. Okay.
Thank you. Thank you, Professor Dempsey.
Thank you.
Now we move to the next talk. Again, Dr. Pucciarelli will talk to us about management of infertility in polycystic ovary syndrome.
Thank you. Another huge topic to cover in 20 minutes, and I will try to do that. First of all, I would like to declare that I have no conflict of interest. In the next 20 minutes, 25 I will say, I will just go briefly through the definition of PCOS and briefly prevalence in clinic, and we spend most of the presentation discussing what to do in terms of diagnosis, especially therapeutical options for infertile PCOS patients, and try to have some final consideration. Unfortunately, we don't have time to discuss about PCOS diagnosis. That will take another entire Congress, and no time to discuss about management and treatment for women who are not trying to conceive, okay? As we all know, PCOS was for the first time described many years ago by Stein-Leventhal back in 1935 as the triad of symptoms that was amenorrhea, obesity, and hirsutism. Later, for many years, there was a big discussion between Europe and US how to define the syndrome. And the NIH stated that the PCOS was characterized by the presence of hyperandrogenism and or hyperandrogenemia with menstrual dysfunction, with exclusion of other disease, a similar clinical presentation. And there was no idea about the ultrasound imaging. That was considered one feature for European countries and doctors. So at the end, in 2003, and Sorry. There was, we arrived, no? No, one is missing. Anyway, this is not working. Okay. We arrived at a consensus in Rotterdam, stated that we can define the PCOS when we have at least 2 of these features, so oligomenorrhea or amenorrhea, diagnosis through ultrasound of polycystic ovaries, and hyperandrogenemia. And this is the worldwide definition used nowadays. But based on the different definition, the prevalence of the disease can vary in the literature from 5 to 15% of our patients. And 4 different phenotypes have been described later on. The classic one with all the features, the NIH one with the ultrasound finding and so on. And the classic is the most frequent, what we find more frequently. And we can definitely clearly state that the PCOS is the most common endocrinopathy affecting reproductive aged women. We don't have time to go through all the symptoms, but we focus on the problem of this patient to have their baby due to anovulation. So, infertility is a prevalent presenting feature in those patients, with almost 75% of these women suffering of this problem due to anovulation, and making so PCOS by far the most common cause of anovulatory infertility. And you can see clearly here in these diagrams. And if you take in account the subgroup of patients with anovulatory infertility, more than 90% has got PCOS. But it's a very singular disease too. So each woman has got his own personal PCOS. So the clinical manifestations are the result of interaction between genetics, lifestyle, that determine the hormonal changes that characterize the clinics of these patients. And it's very important that we think about this patient in a different way now, because this problem, this syndrome, this disease is a reproductive, metabolic, and hormonal disease that affected women from the adolescence to the postmenopausal ages, determining different problems in a young patient and other problems in the oldest patient. So it's so important to take care of them in a multidisciplinary way for all the risks they can have even after their reproductive ages. As we all know, in this patient, the normal dialogue between the hypothalamus, hypophysis, and ovary is totally disarranged. So, and this deals to an increase of the GnRH pulse frequency that determine an increase of the LH pulse frequency, a decrease of this amplitude, and the increase of bioactivity of LH, and decrease FSH pulse frequency. So the stimulation for the ovulation is missing. And on the other hand, we have a patient with many follicles, many potentially oocytes, but due to the variant hyperandrogenism, due to the paracrine dysregulation of growth factors, and due to the hyperinsulinemia, the quality of these eggs is totally affected. Okay, so many eggs, but poor quality. And it's very important, not only in PCOS patients with infertility, but generally speaking with infertile patients, to have a prognostic approach. As I told before this morning, it's so important to find the way, the solution, the therapy to help these women to conceive as soon as possible, because time, age is a key point for infertility in women. So what we can do in this patient, and again, I want to stress, we are talking about PCOS and infertility, that's it. Not all the therapy you can do for other reasons, for other problems. There is no evidence in the literature to support that any tubal pathology is increased in these patients. So the evaluation of the tube patency should be done like in other infertile patients when there is a suspicion of some problems. So tubal patency testing should be considered prior to ovulation induction in PCOS patient where there is suspected tubal infertility. And after we have confirmed there is a normal semen analysis, We are talking about infertility, so we are facing with a man and with a woman. So do not forget the man, because sometimes we are focused about the problem of the ovulation of the lady, and maybe we found a man with a very severe oligoastenospermia. And I remind you that the male infertility is increasing in the year, and so very often we find a couple with both some have problems for fertility point of view. Recently has been published in many papers the result of the work of these PCOS international networks with a lot of recommendation how to manage PCOS patients and how to manage infertility in these patients. Evaluating and assessing how different interventions like lifestyle, drug therapy for the ovulation induction, surgery, and IVF can help this patient to conceive. What about lifestyle changes? Well, it's considered the first step, the first not pharmacological therapy for this patient. There are some data showing that the loss of 5 to 7% of the body weight may be effective to promote menstrual cycle regulation and spontaneous ovulation. And it's true that a recent Cochrane review showed a benefit in lifestyle changes on the androgen level, on the weight and on BMI, but not clear advantages in terms of fertility. Anyway, despite limited supporting data, in terms of randomized clinical trials, lifestyle still remains the first line treatment for management of these patients before thinking about other treatment, especially in those with obesity, severe obesity, with a BMI greater than 35, let's say 30, 35. Because this is beneficial for the health of the patient, for the metabolic, reproductive, psychological benefit, and especially could be benefit for those that at least arrive to conceive, because we all know the risk of having a baby in obese patients. But if you want to treat the anovulation, which drug use? Again, if we watch the literature, if we watch the recommendation, the first light ovulation suggested therapy in the majority of the guidelines of the societies, medical societies, the two drugs always appearing are clomiphene citrate and letrozole. We know clomiphene citrate is over worldwide use for many years. It's part of a family of a selective estrogen receptor modulator, and we use its anti-estrogenic activity on the axis that stimulate the FSH secretion to induce ovulation. Unfortunately, we know that there is this is a mechanism. There is a percentage of patients varying from 15 to 40%, they are clomiphene citrate resistant. That means they don't respond to a daily dose of 150 milligrams for 5 days. And this is especially in women with obesity. So, in the last year, it's been introducing the use of letrozole that unfortunately is off-label in many countries. Letrozole is an aromatase inhibitors molecule, and again, it inhibiting the aromatase transformation enzyme that convert androgen to estrogen, and that determine an acute hypoestrogenic status that release the axis and increase the FSH that stimulate the ovary. So almost same mechanism for a different way. And for many years there was a discussion how the clomiphene citrate anti-estrogenic activity impaired the quality of the endometrium in those patients, affecting the risk of abortions, miscarriages, let's say. And this paper showed that if we compare letrozole to clomiphene citrate on the endometrium, there was the ratio of multi-rate endometrial pattern was much better in the letrozole group on the ACG day, and all the outcome for pregnancy, so biochemical pregnancy, clinical pregnancy, ongoing pregnancy, was better in the letrozole group compared to the clomiphene citrate. And if we look at the literature, the letrozole win almost everywhere. Letrozole was better than clomiphene citrate for ovulation rate per patient. Letrozole was better than clomiphene citrate for pregnancy rate per patient and per cycle. Letrozole was better than clomiphene citrate for live birth rate per patient, and there is no differences in term ovulation rate per cycle, multiple pregnancy rate, and miscarriages rate. But when we had metformin, that is a worldwide used drug for type 2 diabetes, to the clomiphene citrate, and we compare to letrozole, the results are equal. And we are going to discuss later. So letrozole appeared the first-line therapy, but unfortunately, as I said before, in many countries off-label for infertility, so if used for this reason, should be clearly discussed with the patients. But the association with metformin could represent a good alternative and with the same efficacy. On the other hand, there are some pilot results recently published that in the future association between letrozole and clomiphene could be useful on the ovulation, but a very young data, and we need to have confirmation on that. And the concern about the risk for the newborn conceived after letrozole therapy is gone. The literature is clear. According to the current evidence, letrozole used in fertility, including PCOS and unexplained infertility, does not increase the risk of congenital anomalies in newborns. Another important aspect is time. Time is the key for a patient trying to conceive. And so be aware not to keep this patient in a treatment for too much, for too long. Unsuccessful and prolonged use of ovulation induction agents should be avoided. Unfortunately, there is no study telling us which is the best period of time to keep in the ovulation induction before moving to other steps. But we should use our logic. And many papers say that after 6 months of ovulation induction with clomiphene or with letrozole, we should think without conception, we should think something else. Well, could be the association of the gonadotropin association, the stimulation associated with intrauterine insemination, or that could be the first-line therapy in those couple in which the male present a not severe oligoastenospermia. And the first-line therapy is represented by the gonadotropins that are the first-line therapy in those patients with clomiphene citrate resistancy. And studies show that the comparison between urinary gonadotropin compared to the recombinant one are the same for all the outcome. Metformin. Metformin, as I said before, is the worldwide worldwide use for the therapy for type 2 diabetes. And there are some interesting data that could be beneficial over placebo for live birth rate. But nowadays, if we go to the Cochrane review, if we compare metformin to the clomiphene citrate still represent the first-line therapy because it's more, the efficacy is higher than metformin alone. But as I told you before, if we add metformin to the clomiphene citrate, the association comparing to the use of clomiphene citrate alone is much better for ovulation rate, for clinical pregnancy rate, especially in those patients with high BMI. Okay? Another discussion, does the laparoscopy surgery, the ovarian drilling, could be beneficial versus clomiphene citrate? And no. If we compare the result of clomiphene citrate versus laparoscopy, there is no benefit in terms of pregnancy rate, miscarriage rate per pregnancy. But in the clomiphene, and again, if we compare the clomiphene-resistant patient treated with other therapy, in this case gonadotropin, the laparoscopic drilling is equivalent. So the laparoscopic drilling could be considered as a second line, like of the gonadotropin, in the treatment of this patient for infertility, as you can see here. Okay? And which is the next step. If anything, if the first line didn't work and the second line didn't work, then we can move to IVF. When we should suggest to do IVF for the PCOS infertile patient? Well, the IVF is indicated for those who have not responded to the first or second line therapy, or there is a clear indication for other problems, male factor, for instance. Women with PCOS undergoing IVF are, and this should be clearly discussed with the patient, an increased risk of ovarian hyperstimulation. But fortunately, nowadays, we have some therapy that can help us to avoid the ovarian hyperstimulation syndrome. The use of protocol with the GnRH antagonist, the induction of ovulation with the agonist, the freeze-all of the embryos, and then the embryo transfer later on with the cryocycle can avoid this risk in this patient. It could be one solution. But if one doctor wants to use, and still using the analog of GnRH, the agonist protocol, should be aware that adding the metformin can reduce the risk of hyperstimulation syndrome. And as always, this patient should be advised about the risk when they get pregnant, especially if they're still obese, overweight, and especially if they are a state of hyperandrogenetic state. Because unfortunately, there is increased risk for pregnancy outcome in these patients, and should be monitored during the pregnancy for the risk of gestational diabetes, gestational hypertension, and all the risks connected to these pathologies for the babies. This is, let's say, more risky for patients with hyperandrogenic status. The miscarriage rate are not increased in natural conception, independent of obesity, and miscarriage rate after induction ovulation mirror those found in other infertile population. So try to take home some operative message. This could be a flow chart that we can use. So in front of PCOS patients, we have to check the weight. There is an obese patient with a greater BMI, greater than 35, for instance. We should suggest a lifestyle, so diet and physical activity, weight loss. And we can consider, in some cases, the bariatric surgery, but do not forget the risk connecting with the baby for this patient that are opposite to the obese patient. So after bariatric surgery, there is an increased risk for small, for gestational age, premature delivery, and possibility for increased infant morbidity. If we have patients with less BMI or after weight loss, the first-line therapy should be represented by letrozole and clomiphene plus metformin. The second line, gonadotropin or drilling, and then IVF. Thank you. And I hope it's right in Arabic.
Thank you, Professor Pucciarelli. Now the floor is open for questions, please. Dr. Mose, please.
Thank you so much. This was very interesting talk. I want to know your view about ovarian dwelling. Ovarian dwelling. Cauterization. Yeah. In the last few years.
The drilling.
Yeah. In the last years, it was very popular, and many people they used to be fond of it. Now, I think it is becoming less and less. So, what is your view about that?
Well, again, the literature is quite clear. It represents a second-line therapy, and it depends how, I understand that surgeons or people who are of the habit to do surgery can do it, but there is no evidence that it's better than the gonadotropin, for instance. So you should balance the risk and benefit in these patients. I will not do any drilling anymore. I will use gonadotropin because to me it's more reasonable in this case. But in terms of the result on the pregnancy, on fertility are the same.
Thank you.
You're very welcome. Again, should be done properly. The risk is for many surgeons that do too many drilling, and so there is not a benefit. So should be done properly anyway.
Dr. Khulud.
Thank you very much for this simple, nice, simple. You make it very simple for a very complicated and heterogeneous, disorder. Try to make it really simple and easy for, the public, the general gynecologist to find it very easy. It's just a comment. I think when we consider PCOS, we have also not just step 1, 2, 3, 4, but we have to be really, individualize the case. We have to bear in mind as well the financial aspect of each treatment. Letrozole, for example, it sounds very nice and, effective treatment, but we have to consider that it's more expensive than Clomid. Clomid being used forever, and, it's a hell of support in the literature for the safety. I don't think it's, using an off-label will be really simple without a proper counseling. If we bear in mind also the increased teratogenicity with the letrozole during pregnancy, if you compare it to clomiphene, maybe it is more successful and as a pregnancy and everything as a rate if you compare it, but still we are dealing with people who's really obese, okay, with high insulin resistance. If you bear in mind that in the general population, and I'm talking about, a place where it receives all the referral from Bahrain, we have almost 80% of the PCOS population, they're overweight, beyond 35. So I don't see any point in giving letrozole and forgetting the insulin resistant, for example. So I think we have, in PCOS, you have to take case by case. So let's say if she's obese, you probably glucophage, metformin will be really, a starting or a first line. And then a clomiphene, it's available and it's cheap. I mean, we're not dealing with people who's really, very rich. Some people, they can't afford the 70 dinar. You waste their time. Other thing I've noted that you have to always check, we are dealing with a couple. So as you said, we have really to see the, the other member in the company, male. So if there is a male factor, no point in giving this ovulation induction, you go straight away for IVF. So it's really a person, individualization of each case. It's not just drilling, as Dr. Moses said, drilling, people are not doing it anymore. Sometimes it can be okay, why not? I mean, instead of going through, gonadotropin, when this is available in a good hand, because if people doing it really just, routinely, it can really cause a damage to the ovaries. Thank you very much.
Thank you.
Dr. Hafsa,
Thank
please.
You. Hello? Yeah. Thank you so much for your comment. I totally agree with you. The American used to say, one size does not fit all. And each woman's gone his own story, his own PCOS, and what to do should be discussed with her and with the couple for infertility. I'm not saying, I'm just presenting the data of the literature, but it's clear, if you are, you have the habit to use clomiphene citrate, for instance, just add metformin maybe, and you have a good result. But I totally agree with you. Thank you.
Good morning. Do you routinely do a GTT before using the metformin for this kind of patient with PCOS, or will you go with the history? Well,
in obese patient, I will not do it. I just go through the metformin. In the thin patient, when I suspect if I want to use the metformin, sometimes you have not obese patient, even thin patient with a lot of insulin resistance. In the thin patient with a clear anovulatory problem with the PCOS, I will do it to have an information if had or not had the metformin.
Okay, I will go back regarding my colleague when she raised a point regarding the teratogenicity of the clomiphene compared to the letrozole. There is a huge study has been done in Montreal, Canadian group, and compare the effect of clomiphene citrate and letrozole and the teratogenicity, and they found the risk is the same, is around normal pregnancy, 0.1%. And the cost of the letrozole is very cheap in Bahrain, 5 tablets around 7 to 10 BD. Thank you.
Thank you for the comment. Yeah, the cost is another thing to be pushed on the balance.
Any more questions? Okay. In conclusion of this first session, I would like to thank on your behalf our speakers for their scientific good lectures, and I would like to thank all of you for attending these sessions and wishing you a very good day. Now we go for a break. Thank you very much.